One of the newest frontiers in spine surgery has been the option of motion preservation as opposed to a fusion. As you know, each spinal motion segment is a shock-absorbing disc in the front and facet joints in the back. And one of the things I'm very excited about, and Dr. Ament, my partner, has truly pioneered this, is to be able to do a 360 motion preserving operation. Because our problem before has always been, do we treat the disc first or the facet first? Which one is the pain generator? It's always a diagnostic dilemma. And now we have the option for the first time through a research protocol to perform a 360 motion preserving operation.
When you get a knee replacement or hip replacement, they're not using concrete blocks, they're using articulating moving joints. And so Dr. Vokshar and I have looked at this for a long time. Why would the spine be different? Now, if there's frank instability, it's a different discussion. One of the aspects that's critical to motion preservation technology is when we can do it and when we can't, what are our limitations and why? And the biggest limiting factors to doing an artificial facet, tops from behind, is an incompetent or inadequate disc shock absorber in the front.
That's correct.
We went to several meetings, we talked about this, and there are other technologies that have been used to look at anterior in the front and posterior in the back, supportive mechanisms for motion preservation. And I said, well, heck, if one of the exclusion criteria, one of the reasons why you cannot get an artificial facet is because the disc is not adequate, why don't we replace the disc? And if one of the reasons you cannot get a disc, an artificial disc, is because we're worried about posterior behind facet disease, why don't we replace the facets? And so it seems logical, right? But we're doing this under the auspices of a trial, a pilot trial. We have some new interest of sub-investigator, other sites that want to come in and join our trial and our protocol, because we want to do this ethically. We want to collect data. We want to make sure that it's more than just logical. It's efficacious. It clinically works. And look, we are using 2 FDA-approved devices in an off-label, non-FDA tested setting. So the question will be biomechanics. Logically, it makes sense that if a disc works with facets and you're replacing the facet and the facet should work, it should work. But we don't know that. It hasn't been tested. So we believe quite adamantly that this is an ethical attempt to help people prevent a fusion, but we do not have long-term data. We do have some. 6 months, I have a patient with a year out. The patients have done well, but this is so early. We cannot make that as a blanket statement that this is a success. We don't know that yet. This is early times. We are both committed to trying to prevent fusion when appropriate. And it's an exciting part of NSG in our practice of what we're doing. We're doing it, and we're also able to do it in an outpatient at our surgery center here, which is extremely exciting. Some patients go to rehab, the outpatient kind of post-op rehab for a few days, but overall, patients are doing well. It's early days, but it is one more example of how Dr. Vokshar and I are trying to push the envelope in a safe way for our patients to prevent fusions and keep moving.